Thanks for joining me today for the second of our two-part program on how employers can increase medication adherence through benefit design. My name is Carole Florman. I'm a policy fellow for CancerCare. This is a short presentation, just about 15 minutes, and if you have questions, please put them into the Q&A box and I will be happy to answer them at the end. Now, for those of you who didn't join us last week, here's a little information about CancerCare. We are a 78-year-old nonprofit organization that provides no-cost services to anyone impacted by cancer. This slide shows our direct impact in fiscal 2021. You can find us on the web at cancercare.org. Now, the problem we're talking about today is medication non-adherence. As you see, it costs the U.S. economy $100 to almost $300 billion annually and leads to 125,000 unnecessary deaths per year. Last week, I described the problem of medication non-adherence, which is, as you see, a hugely expensive problem that's created when a patient forgoes their prescribed treatment for a number of reasons, including cost, administrative burdens, or complexity of their treatment regimen. This week, I want to talk about the connection between benefit design and medication adherence. And I'm also going to share some recommendations on ways in which you can improve your benefit design, and that can help drive adherence and improve your employers' health and satisfaction. Formulary design is a really key part of medication adherence. A plan's drug formulary is important to patients, and it can play a key role in adherence and in non-adherence. Formularies are designed by insurance and pharmacy benefit managers, also known as PBMs, but the process for doing so is usually pretty opaque. Formularies can be open, which allows access to all FDA-approved drugs, or closed. Now, big problems can occur when formularies limit the number of drugs in a clinical class, particularly as medicine becomes more personalized and targeted. Different drugs that treat the same condition might work very differently for different people, and an overly restrictive formulary might force someone onto a less effective treatment or one that causes significant side effects. Now, one might assume that formularies are based on effectiveness and price, but that's not always the case. Rebates from drug manufacturers play a significant role in which drugs are on formularies and which tier they're placed on. Now, if you look at formulary lists from the major PBMs, you'll often find very expensive drugs covered, while lower price alternative drugs for the same conditions are not included. Or there's times when a brand name drug is on the formulary, but the generic is not. Now, rebates from manufacturers are a key reason for such illogical benefit design. Now, another problem is non-medical switching, and that's when a patient who is stable on a particular drug is forced to change their medicine because of a formulary change, not because their doctor thinks they should be on a different drug. And this can happen even in the middle of a plan year, which is not only very disruptive to patients, but think about it, it's pretty unfair if the patient chose that particular plan because the drug they needed was on their formulary. Last but not least is high pocket out of costs. There's a direct and measurable correlation between out-of-pocket costs and adherence. As patient costs increase, adherence decreases. Now, a very common feature of prescription drug benefit plans that affect patients is coinsurance. And that's where, instead of a flat copayment, patients pay a percentage of the drug's costs, let's say 30%. Coinsurance is a particular problem for people who are on expensive specialty drugs, such as cancer drugs, and it may require payments of thousands of dollars, which most people can't afford. Now, on the right side of this slide, you see Patricia Goldsmith, and she's a real patient who experienced problems because of her health plan's formulary changes. She experienced non-medical switching. Now, the slide deck includes links to 3 different patient stories, each of whom experienced health setbacks due to specific aspects of their employer's benefit design. You can use the QR code at the bottom there to link to a short video that explains the benefit design issue and hear directly from the patient. And these videos can also be found on the CancerCare website. Now, there's a better way to do formulary. It can be improved by basing the covered drugs on clinical considerations, in other words, science and patient needs, rather than on PBM profits. Adherence can be improved when patients who are stable on a particular drug are allowed to stay on that drug, even if there's a change to the formulary. Patients should only be required to change drugs for medical reasons. Now, most disease states, except for very rare conditions, have multiple drugs that treat them. And it's important that those drugs be placed on different pricing tiers. Let's say you place all the anti-cancer drugs on the highest specialty tier. It gives patients and clinicians very few options. Generics should be always covered, and they should be on the lowest tier on the formulary. This encourages their use and saves money for patients and plan sponsors. Making patients cost share a high priority is a really important way to improve adherence. Charge the lowest copays you can, or in the case of drugs that treat chronic conditions such as diabetes, consider having no copayment for the drugs and avoid using coinsurance for prescription drugs. Prior authorization, also known as PA, is supposed to ensure that services and treatments are medically necessary, which can help contain costs and protect patient safety. But in reality, prior authorization can delay treatments, restrict access to the most appropriate medications, increase the administrative burden and costs to clinical practices, and increase non-adherence. Now, PBMs and insurers continue to increase the use of prior authorization, even though most PA reviews are eventually approved. So you have to ask why it's such a popular tool. It may be because more than a third of prescriptions requiring prior authorization are abandoned by the patient while they're waiting for that review to take place. Now, does that save money? In the short term, yes. But when a patient is non-adherent, they're likely to become sicker, experience medical complications, more hospitalizations, and increased medical costs. Here on the right, again, is another case study about prior authorization. Amy is a multiple myeloma patient. And again, if you use your phone to click on that QR code, you could go to her story. Now, here's a question. I'm not doing a formal poll today, but just shout out a number. What percentage of physicians report that prior authorization requirements have led to a serious health incident for a patient? All right, I can't hear you, so I'll tell you. It's 34%. Now, that's a pretty big number. And now this comes from a recent survey by the American Medical Association of more than 1,000 practicing physicians about the impacts they see prior authorization having on their patients. 1 in 3 doctors said that prior authorization led to one of their patients requiring hospitalization, being permanently disabled, or worse. And for physicians that treat patients between the ages of 18 and 65, which is generally the working population, a majority said that prior authorization interfered with one of their patients' abilities to do their job. And despite what insurance companies and PBMs claim about their reasons for using prior authorization, 30% of physicians said that prior authorization criteria is rarely or never evidence-based, despite 98% of health plans claiming to use evidence-based studies to design their programs. Prior authorization is a tool that should only be used when there's a problem. It makes sense to require prior authorization for drugs that are frequently abused or have another specific concern, such as interactions. But it should not be used for first-line therapies, and those are the drugs that are generally accepted as the best treatment for a specific condition, or for generic drugs, or for drugs that are approved 90% of the time, or those drugs that do not have an alternative to treat a specific condition. Prior authorization policy should be based on current standards of care and kept up to date. For example, you should not require prior authorization for a drug that may have recently become a first-line therapy. Prior authorization shouldn't be required for patients who are stable on a drug when they're renewing their prescription or if they're new to your prescription drug plan. And prior authorization should be handled electronically with immediate decisions in most cases. This is known as EHR. It speeds up the process by sending prior authorization documents digitally instead of via phone or fax, which is still done. And that can help eliminate delays that are very common with prior authorization. You could also waive prior authorization for trusted clinicians. This is called gold carding. And that really talks about doctors who have most of their PA requests for a certain drug approved during a specified period, then are exempted from PA for that drug. And this is actually the law now in Texas. Step therapy is often called fail first protocol because it requires the patient to try one or a series of cheaper drugs before receiving approval for the drug their physician thinks is the right drug. Now, this can often result in patients having a lengthy delay in receiving effective treatment while they're paying for ineffective drugs. Many plans will force a patient to retry a drug that's already failed if they're new to the insurance plan, or they'll require patients who are stable on a drug to step down to a lower cost drug, even though the one they're on is working. Now, patients may experience side effects from the preferred drug, or they could have their conditions worsen while going through the step protocol process. Cancer drugs are very often the targets of step therapy. And as cancer care becomes more precise and personalized, forcing patients to try a drug that is not the right one for their condition can result in their cancer spreading while they wait. And of course, forcing someone off a drug that is working can sometimes even make it impossible for them to return to that drug safely after the other drugs fail. Step therapy is linked to increased complications and medical costs from having people on the wrong medicine, from delays in getting them effective treatment, and due to medication non-adherence when a patient is preventing from getting the drug they need and they just stop treatment. Step therapy has been shown to worsen long-term outcomes and survival when it's required for people with cancer and other serious conditions. Once again, we have a case study here about step therapy, Justin Williams, and I do urge you to watch his video and hear from him about how step therapy really messed up his life and made his condition worse. Now, there are ways to make step therapy safer for patients and less likely to lead to non-adherence. Many of our recommendations come from a proposed federal law, which is called the Safe Step Act, and that would require group health plans to establish exceptions to medication step therapy protocol in specified cases. Now, you can limit the use of step therapy to less serious diseases and conditions, but you shouldn't require it when a delay in getting the right drug can make a serious condition worse. Patients should not be subjected to drugs that might harm them, nor should they be forced to step down from a drug that they're already stable on. And no one should have to try a drug that has failed a second time if they've already undergone step therapy for their condition. If step therapy is appropriate for a specific condition, steps should be limited to one failure before getting the drug that their clinician thinks is best. Now, this isn't just common sense. 38 states have already passed laws placing limits on step therapy, and more are considering legislation. Now, if you're in a ERISA plan, obviously that doesn't apply to you, but maybe you could do it anyway because A, it's the right thing to do. It will help your employees. And, it probably is going to pass at the federal level at some point. CancerCare has created a toolkit, the Employer's Prescription for Employee Protection Toolkit, And that provides recommendations and actionable tools to help employers design better prescription drug benefit plans. The toolkit explains the unintended consequences of utilization management techniques like prior authorization, step therapy, and others. And it offers very sensible recommendations to improve how utilization management is done. It provides questions you can ask your benefit consultants, your PBMs and insurance companies, and your third-party administrators. And it provides language you can include in RFPs and summary plan documents. You can download our employer prescription benefit toolkit on the CancerCare website, or go directly there to betterrxbenefits.org, and you can view the accompanying videos. I also invite you to scan this QR code here to request a full presentation of the toolkits and its recommendations. Now, I am now happy to answer any questions that we might have. I see there's one in the box. And this question is, if there's one thing you can focus on, what would it be? Well, all the things I outlined, I think are important, but if you're really only going to focus one, look at out-of-pocket costs. The out-of-pocket costs, as I said, are directly linked to people's adherence. And if you can eliminate non-adherence by making copays low or not having copays, by not having co-insurance, and making sure that generic drugs are available, people are more likely to stick to their plans. I think that's it for the questions. So I will thank you for joining me today. And again, I do encourage you to visit us at cancercare.org or betterrxbenefits.org and do request a full presentation for your organization. Thanks very much.